हॅलो.
हॅलो, हा सर बोला.
हां, अच्छा मला वाटतं हे व्हिडिओ ऑफ आहे. कोणी आलं का? कोणतरी आलं का?
डॉक्टर हादी मांजी आले. व्हिडिओ मी स्टार्ट करू शकता तुमचा?
नाही, तिकडून असं आता सुधीर पण नाही, परत बंद झालं.
नाही मीच आहे.
अच्छा, तुम्ही आहे.
Hello.
Hello. Good evening.
Hi, good afternoon. Good afternoon.
Yeah, good afternoon. How are you?
Yeah, fine, thank you. I just undo this. I'll put the light on. So maybe that's a bit better, I think.
Yeah, it is 2:15 would be there now, 2:20.
Yeah, no, it's 2:15.
Yeah.
So these are excellent. I've tried to pass on the links to as many people as I can.
Yeah.
I think it's very helpful. So at the moment, the temperature here is 35 degrees.
Okay.
So it's very, very hot at the moment. But anyway, how are things there?
Yeah, fine, good. It's raining intermittently. Yeah, it's rains now.
Right. Okay.
Yeah.
And
But the biggest danger is of COVID.
Yeah, it's
now daily more than 60,000 patients and around 800, 900 deaths daily in India. Yeah.
And where are you based?
I'm in Nagpur, center of India.
Right. And
yeah, Nagpur is not that bad.
No, yeah. And then, so you're seeing a lot of neurology complications?
Yeah.
Stroke and
yes,
ADEM and stuff.
Ja, wir sind schon drinnen. Bravo.
Hello?
Hello, Dr. Kochar. Good evening.
Hello.
Hi. Excuse me 1 second.
Yeah.
Get some water.
Hello. Nice to see you.
Hello.
Hello. We still have.
Hello.
Hi, nice. We still have 10 minutes to go. Is that okay?
Yeah.
Okay.
That's perfectly fine.
So we'll drive. Thank you. We'll drive a little bit because we're in the middle of nowhere at the moment.
Yeah.
And continue driving for the next 2 minutes. Thank you. Das ist ein Kollege aus Indien.
So how is there? You're doing fine?
Yes, thank you very much. And you?
Yeah, we are all well.
Very good. Well, congratulations to this wonderful incentive. I think this is very nice and very exciting.
Thank you. And
Yeah.
People are asking that we should extend it further. There
Yeah,
are
sure.
so many important topics.
I'm sure. No, I'm sure that's an excellent idea. And it's very communicative, isn't it? I mean,
Yeah.
to have a full lecture on a topic.
Yeah.
So how will we do it? When at 3:30 when it starts?
Yeah.
I will introduce Riyadh. Is that the way we do it?
Riyadh will join. He said he will join.
Okay, and then I will speak this slide. Just give a few words.
So the plan is that I will introduce you and Adi Manji.
Okay.
And then you introduce Riyadh.
Very good, thank you.
And then you invite Riyadh to give a talk. And then you take on the question answers.
Okay.
And so
the question answers come by chat, right? Or how do I receive them?
Yeah, they come on this question answer box at the bottom. Yeah, at the bottom of the screen. Yeah,
Okay,
Riyadh is here. Hello.
Hello,
Yeah. How are you? Nice to see
how
you.
are you going?
Hello, Riyadh.
It's amazing, 3 continents.
Yeah, it's and easy, comparatively easy. I mean, it's incredible. A little bit flashing because I'm driving. I'm driving, he's driving. But we're almost at our destination, so the internet is a little bit shaky. I think we do it.
Hello.
And then
Doctor,
may I ask,
Dr. Gagandeep has also joined. Hello, good evening.
कैसे हो? How are things?
First class. So the speaker and both chairperson are here.
Excellent, excellent.
Good.
And the course director is also there.
I have to be there to, welcome everyone. And I think. So how is Riyadh? How is the COVID situation there in Tunisia and that part of the world?
It's summer, it's very hot, very,
Okay.
very hot.
Really?
It's also politically hot. And that's it.
Hello.
Oops.
You met Dr. Gagandeep before, Riyadh?
Pardon me?
You met Dr. Gagandeep Singh before? No.
No, no, no.
No, Gagandeep Singh is Secretary of Indian Academy of
Hello.
Nice to meet you, Dr. Gagandeep.
Gagandeep, and he is the moderator and he's selecting cases for this session.
Very good.
Hi. No, but I think we met. Sorry. Hello.
Hello.
So did you come to Limoges at any stage, any point, one of the meetings at Limoges?
No, no. I was once in New Delhi.
Right.
It was your Asian Ocean meeting in 2008.
Right. The neurology meeting.
Yeah, the neurology meeting. That's the time I was there. It was the WFN did their Council of Delegates.
Okay.
Yeah, that was in Delhi, I think, in India, no?
In New Delhi in 2008.
Yeah, 2008 Delhi, yeah.
Yeah.
Right. So we are really looking forward. I think we probably in India, we miss a number of cases of neurobrucellosis. We tend to diagnose them as TB spine,
Yeah.
Yes. This is what I will try to enhance in this talk, that we as a neurologist have to think about neurobrucellosis, especially in our areas.
Yeah.
And you know that we have people that go to Europe, for example, and have neurobrucellosis, but they are not so familiar there with this disease, and they come again to Tunisia, and we diagnose them because we have cases due to migration of sheep and things like this in all the regions. So it's a diagnosis we should think about. That's what I will give as a principal advice in this talk.
Excellent.
Yeah, I think once you start suspecting, you diagnose it more. Because in last 2 years, I have seen about 5 cases of brucellosis.
Yeah, this is what I'm saying, and we are missing a lot of them because neurological manifestation can be the first manifestation, and this is something that we really miss. We don't go to neurobrucellosis as we have to do.
how is the COVID situation in Tunisia?
We have 1,200 patients only and 50 deaths. So the situation was controlled for the first wave, but you are experiencing a new wave, a new second wave now. And I know, I see that in India, the number are rising.
Yeah, the numbers are going up. So it's huge numbers. Yeah.
My real fear about COVID is that we can have, I would say, a neurology second wave later.
So you think neurological manifestations will come in?
Yeah, like it was for the Spanish flu. This is my real fear, because they're speaking about cognitive manifestation later on.
So, yeah. But Spanish flu was bad. There was bad neurology in Spanish flu. Should we start? Hi, Sudhir. How are you?
I have allowed everybody to join just now. So
Yeah, I think we still have 4 minutes to go.
yeah, let people join. How are you?
Yeah, hi Sudhir, how are you? I'm fine, thank you. Wolfgang, hello.
Hi.
Hello, Manji. How are you? Nice to see you.
Yeah, nice to catch up. Sudhir, I need to speak to you later on about the meeting we're doing.
Yes.
We
Still have to record for the Romanian. So I'm going to do that tonight.
Yeah. Do you want to announce about the Royal Cytometry joint meeting? Yeah.
Yes. Srikirti was going to get the announcement brochure made.
Yes, I think that's been done now.
Okay.
I'll make sure she sends it to you. It should be on our website.
So we should start sending out the.
Yeah.
There are so many webinars going. So many.
Yeah. Well, you don't have to travel anywhere, which is something.
Yeah.
We're stuck.
Welcome.
Oh.
So, Hadi, how are
Hello,
the
Professor Anita.
clinics?
Good evening.
Hello.
How are the clinics? Have they?
So at the
patient
moment, yeah, no,
numbers?
we're starting face to face now. We'd stopped all face to face apart from emergencies. So now we're starting up again, but it's it's very slow. And I must say, doing telephone clinics, it gets boring after a while.
Yes.
It does. It does.
You know.
Yes.
And I can tell that you know at least that's what our experience is that patients are not really satisfied, so they would want a face-to-face after that, just in order to show their face. And
especially new patients, you know, it's very difficult to assess.
new patients, I'm talking about old patients. New patients,
even then,
it's too difficult actually. Yeah.
And the other problem I am facing is you spend at least 5 times more time in.
Takes longer.
You take longer.
Takes much longer. Yeah.
It takes longer. Yeah, no, it does. But it's a new world. So we've published our findings from Queen's Square in Brain about a month ago on the neurological complications we've come across.
Yes, we saw that. Yeah.
And I think now there are a lot of papers coming out from everywhere, but they are all observational. The mechanisms are still complex, I think, and I think we need more neuropathology to tell us what's actually going on. Whether it's this sort of immunothrombosis that seems to be a flavor everywhere.
there is also a little bit invasion, isn't there, from the olfactory thing?
No, there's no evidence of that. There was in animals, but there's no direct evidence yet that
There was
COVID
some,
actually
sorry, there
infects.
was MRIs of the olfactory region of the brain being abnormal in those with smell. I don't.
Well, I think it's the epithelium which gets infected by COVID. But I'm not sure they've actually shown direct invasion. I don't know if anyone's actually shown the virus in the brain. We never found the virus with PCR. That doesn't mean it's not there, but so far the evidence of the virus inside the brain itself is pretty minimal, which may be a good thing.
But you have clinical evidence that it is the epithelium. We've done a work, retrospective ones, seeing how it goes with the anosmia and the agasia, and it's just a period of, I will say, 2 weeks, 3 weeks, and it comes to normal, which means it means that the epithelium, it is, and directly it means that this is the epithelium time for the epithelium to recover. Because if it is a neurological involvement, it will not take 2 weeks to be, and this is what we discussed. I think that we should have a paper rapidly on now, because it is on the track. And just there is no evidence that the clinical one, that the nervous system is affected in anosmia or ageusia.
I think what you were talking about was encephalitis lethargica after the Spanish flu,
Yes.
We did look at it, but in fact, the phenotype is very different, and the age group was much younger for encephalitis. Between 10 and 30 were most of the patients.
Yes.
I think they need follow-up. These patients will all need long-term follow-up.
But there is reports now for people time later on having cognitive impairment, some cognitive impairment, especially those who have had severe forms. And they have, there was reports of cognitive impairment in these cases.
Yes, yeah. It's now called long COVID, right?
Yes.
Okay. Should we begin?
Yeah, I think we should begin now.
Yeah.
Okay. Friends, welcome once again. It is Saturday evening, the WFN-FINE Neuro-Infection series, and this is the fourth in the series. I must say, having attended the first three, they've been highly instructional. They've been highly exceptionally good, and I've learned a lot. Extremely grateful to the course director, Dr. Meshram, and I'll very soon pass on the mic or the mic to Dr. Meshram to introduce firstly the chairpersons, Professor Wolfgang Grisol, the Secretary General of the World Federation of Neurology, and Dr. Hadi Manji, who's a noted neuroinfection specialist, very well known and an astute clinician. By the way, Dr. Manji, I really enjoyed one of the CPCs. I still have memories of one of the CPCs that you did in Mumbai.
Oh, I remember it very well.
Yes.
I got it wrong.
but it was, the discussion was fantastic. And then, of course, the chairpersons would introduce the renowned speaker for today, Professor Riyad Godier. And then we have three cases. So I request Dr. Meshram to inform all the delegates about the structure of the program and introduce the chairpersons so that we can proceed ahead. Dr. Meshram, please.
Thank you, Dr. Gagan. Dear friends, good morning, good afternoon, good evening, buenos dias, bonjour. On behalf of Tropical and Geographical Neurology Specialty Group of World Federation of Neurology and Forum for Indian Neurology Education, I welcome you all for this fourth session of WFN-FINE Neuro-Infection series. The previous three sessions have been very successful and we got very encouraging feedback. In the room today, we have today's speaker, Professor Riyad Gauder, chairpersons, Professor Wolfgang Griswold and Professor Hadi Manji, invited panelists, Dr. Satish Khadilkar, case presenters, Dr. Ashish Bhutra, Dr. Abir Goyal, and Virinder Pal Singh, moderators, Dr. Gagandeep Singh and Dr. Rahul Kulkarni, Dr. Sudhir Kothari is trustee of FINE, Dr. Anita Mahadevan, Professor Raj Shakir. I welcome you all. Professor Griswold he's a professor of neurology at the beautiful city of Vienna in Austria. He's board certified since 1984. He's the Secretary General of World Federation of Neurology. Member of Austrian Society of Neurology, European Academy of Neurology, PNS Society, in American Academy of Neurology, Society of Neuro-Oncology and European Academy of Neuro-Oncology. He has a special interest in neuromuscular diseases, neuro-oncology, palliative care, advocacy, and education, and also history of neurology. He has very successfully organized World Congress of Neurology 2013 in Vienna and International Neuromuscular Congress in 2018. He had more than 250 PubMed publications. He has written several books. Warm welcome to you, Professor Griswold.
Thank you very
Another
much.
chairperson, we have Professor Hadi Manji. He's a consultant neurologist, National Hospital for Neurology, Queen Square, London. He's trained initially as general practitioner in Edinburgh and subsequently in neurology at Queen Square, London and in Paris. He has published very widely in peripheral nerve disorder, neuroinfections, including HIV and recently COVID-19, and also in movement disorders. We read the Oxford textbook of neurology, and he is the editor and author of Oxford textbook of neurology. And the third edition is in preparation. He is currently president of neurosciences section of Royal Society of Medicine. Welcome, Professor Hadi Manji.
Thank you, Meshram.
The invited panelists, we have Dr. Satish Khadilkar. He is the Dean, Bombay Hospital Institute of Medical Sciences, and his specialty is neuromuscular diseases. The case presenters, Dr. Ashish Bhutra is a consultant neurologist at Shri Markandeya Solapur Rugnalaya and Yashodhara Super Speciality Hospital. Dr. Abir Goyal is senior resident in Department of Neurology at PGI MER Chandigarh, and Dr. Birinder Singh Paul is professor of neurology at DMC Ludhiana. So we are going to have a very interesting session. Professor Riyad will speak on neurobrucellosis. Then we'll have a question answer session. And after that, we'll have three case presentation. And you can interact with the speaker and the case presenters. And I'm sure that you will enjoy this session. Thank you very much. Over to Professor Griswold and Hadi Manji to do further proceedings.
Okay. Hadi, is it okay if I introduce Riyad? Is that fine with you?
Yeah, that's fine, and I'm happy to do the cases. Yeah.
Okay, great. So thank you very much, Meshram, and the team of the specialty group on tropical neurology. And I want to congratulate you on this excellent series, which is really enlightening. Today's presenter will be Professor Riyad Gauder, who is from Tunisia, and I will give a short CV. He received his medical degree in 1993, his diploma in neurology in 1994, a master in human genetics in 1999 from the Faculty of Medicine of Tunis, and a diploma of clinical neurophysiology in 1993 from the Faculty of Medicine of Paris, Salpêtrière. He's presently the head of Department of Neurology at the Razi University since 2002, and which has an Alzheimer's Center since 2010 and an MS Center since 2018. We work together in his eminent position as a trustee, and he's a trustee of the World Federation since 2014 and has contributed a lot in his work to the communication of Africa, the Arab countries, and any kind of communication. He is a member of the European Academy of Neurology, and I think he also is a special member, and he's a fellow since 2018. He's also a member of the American Academy of Neurology, the AAN, since 2012, and a fellow since 2019. He's the honorary president of the Pan-Arab Union of Neurological Sciences, PANS, since 2013, and the honorary president of the Pan-African Association of Neurological Sciences, PANS, since 2016. He is, and that's important for the present situation, a founding member of the African Academy of Neurology, AFAN, and its honorary president since 2016. He authored and co-authored more than 160 original papers and book chapters, and his main fields of interest are dementia, epilepsy, multiple sclerosis, neuropathies, and I would say anything that has to do with neurology. But that's my personal comment, and it's meant as a praise. Today he's going to talk to us about brucellosis, which, as we heard, is sometimes a neglected disease. And Riyad, welcome, and we're looking forward to hearing your lecture.
Thank you very much, Wolfgang, for this kind introduction. I'm also happy to be a friend of you and Professor Mishra more so. And we are militating a lot on WFN, on working on several fields. When I speak of WFN, I was very happy to see that the course was in memory or dedicated to Professor Chopra. I witnessed the activity of Professor Chopra as a young neurologist in the beginning of my activity in WFN. And personally, I was very impressed by his knowledge, by his wisdom, and hope that I will contribute with a talk that it is on the minimum at the level what we would expect if he was with us. Thank you again, Mashon, for this kind of invitation, for idea. I saw that in the page Facebook of the African Academy, there was a lot of advertisement of this event in the several times that you had these courses. And I hope that also my colleague from my African or Middle East region are also seeing this, either directly or on the YouTube channel. So my talk today will be on neurobrucellosis. I have just to share the screen before. I'm sorry, I have just to have the figure of sharing the screen that doesn't count.
Yeah, there is, Riyad, there is a green button.
Yeah, I'm talking this green button now. But I just want to, yes, I am coming on 1 minute, I'm sorry. Okay. That's the presentation here. Okay. Okay. You have it?
Yes.
You've started
Yes, yes.
sharing your screen.
Now going to full screen. Is it okay?
Yes.
Okay. So Neurobrucellosis is, I will see a very, very misleading disease for us neurologists. I have no disclosure on this, for this presentation, and I will go through all these chapters in my presentation, from the introduction to at the end, the treatment and the conclusions. And the brucellosis has several names. One of them is Malta fever, Mediterranean fever, which means that the Mediterranean region was the place where the disease has been described at the beginning, especially in Malta, and this is why you have, after this, Brucella melitensis. What people don't know always is it's the most frequent ubiquitous anthropozoonoses. So it is 500,000 new cases each year. And as I said, it's the most frequent. We should have it because now you see how travels are changing things, how movement of population are changing things, and we should have it always in mind. As I say, the historical overview I want to do is the following. From Hippocrates, the brucellosis was described. He already described a case of undulant fever, but the real description came later on, and it came especially by a physician from the British Navy who described things happening in Malta, and he made the diagnosis, the differential diagnosis of various fevers affecting soldiers. And you will see that even also our country is involved with this. There's a lot of pioneers for neurobrucellosis, but one of these pioneers is Charles Nicolle. Charles Nicolle is a French microbiologist who worked in Tunisia. He was the one who discovered the typhus, and who was awarded of Nobel Prize on his work on typhus. But he made a lot of work also in brucellosis, and he described the clinical, serological, and bacillary description in our North African region. That's what I was saying on the overview. You can find brucellosis on several names: Malta fever, undulant fever, Mediterranean fever, rock fever of Gibraltar, gastric fever, or on the animals disease, animal disease, Banks disease, on zoonotic abortion, etc. You can find it under all this name. As I say, it's the most common zoonotic disease in the world, but the prevalence is very different from a country to another. And you see this, the world map showing that there is a lot of differences between countries. Even there's not a statistic description, but it is an old map that is ranging from more than 10 years, who shows that there's country where the disease is endemic. And I will just make a clarification. Tunisia is this country which is in the northern part of Africa, just behind Italy. And you see that on our neighbor, which is Algeria, have a very high endemic situation. And even we were able to eradicate at the moment brucellosis, it came after because sheep doesn't know borders. And the movement of animals from the frontiers, even it was controlled at this time in Tunisia, we had a new wave of brucellosis who is becoming again endemic in the northwestern region of the country. So you cannot say that the situation is done unless in all the region the problem is solved. And this is an example of human brucellosis showing that in the Middle East, this is a paper that we published on 2018, and we took all these countries that do a review of this, and you see that there are countries that can have incidence going more than 100 for 100,000 inhabitants. This is also found in the Middle East region, especially Iraq, Iran, and Saudi Arabia. And when you know that for the pilgrim, all the countries go to Saudi Arabia, they are all at risk to have the disease if they go with raw milk or special way of cheese. This epidemiology is also having in account seasonal factors. You have countries with temperate or cold climate, and there you can have peak of brucellosis. While in tropical and subtropical areas in Africa, there is no seasonal influence, and the animal breeding extends through the year, so there's not a lot of difference. Just a quick thought to my colleagues in India who are seeing us. Human brucellosis in India is also increasing and veterinary public health problem. And just Misha now said that he has seen the last time 5 new cases, which means that if he has seen this, that the situation is becoming endemic, and at this time it is more and more difficult to eradicate the disease.
Dr. Riyad, can I interrupt you for a minute?
Yes, of course.
Can you change to full screen mode instead of presenter mode?
Okay.
The top, go up. The one on the next to FINDO diaporama, the parameters, what is that? If you click that, the top third. Yeah, now go to full screen. You can presenter the link. That yes, left on the. I think that will do. Yes.
This one?
Yeah.
So I think he should do the first one.
I'm sorry to bother you.
Now go down on the right. You can see right, but yes. Okay. Click that. Click that.
Click that.
Not personalis. I think.
So the first one,
Right hand. If you go right down, there is an icon at the right corner below, which shows the monitor. If you click on that monitor, it will start.
Okay.
So where you have the percentage of the screen, right hand side below.
Yes. That
icon, yes.
Is it better?
Yeah, yes, correct. Perfect.
I'm very sorry to bother you on this. I'm very, very sorry. Okay, so did the slides of the beginning okay, or should I repeat? Was it okay? Hello?
Continue, Riyad. It's fine. I think it's perfect now.
Okay, I continue. So the Brucella is gram-negative Coccobacillus, and an important information that you should keep in mind, it's an intracellular organism, and this is important for the therapeutics later on. There are more than 10 species who are all Brucella. and you will see that it will depend on the animals and how it goes to humans. The four that you should keep in mind are Brucella abortus, Brucella canis, which come obviously from dogs and wolves, Brucella melitensis, these are from goat and sheep, and Brucella suis from pigs and wild boar. So these are the four most important groups that you should keep in mind. The Brucella melitensis, which was described in Malta, was the most prevalent worldwide. The distribution is Mediterranean and Middle East. The principal hosts are goat, sheep, and camel. And I want just to tell a story how they work. At the end, people convinced that the goat was a problem. In Malta, the people were selling milk from house to house with the group of goats, and you have the very fresh milk. And when the English doctor I speak about, who made the discovery and explained to people that they should not have the goat milk like this, the farmers got on a strike. And the people remarked that under the strike, there were less fever. And this was the most convincing argument for them to stop having raw milk and to go to pasteurized milk. Just to say that it is something going with the habits of people, and when you know that this problem, you have to solve it. The Brucella abortus is coming especially from cattle, and it's distributed worldwide. It has been eradicated in some country, but it's really variable from disease on another, and it's especially a cause of poverty. With this Brucella abortus, you have a loss of a lot of abortion in animals and loss in the shelter of animals. Brucella suis is coming from the swine, and there's a risk of infection in hunters of pigs and wild dogs. The Brucella ovis, the principal host is the sheep, and it is found on the West Pacific region and with Australia, New Zealand, and the western part of America. But you have also, it was present also in countries in Europe. Now it is considered for the measure of time eradicated. Brucella canis is coming from dog. And just to say to you that the contamination can go from the animals through milk, through cheese, and even we will see from other way of transmission. The oral portal of entry is the most common route, but people who didn't took raw milk or its derivatives can have also contamination through inhalation of bacteria when they are in contact. And one of the stories that I want also to give, because we can speak about, is the one reported by our Sudanese colleague, who made the diagnosis of neurobrucellosis in American soldiers in Sudan. And the American doctors were sure, no, he has never been in contact with milk with raw. And the single contact that he had was that he was on a helicopter, was used just a little time before on displacing some of the animals. And that's the only way he would be contaminated. So it is very rare, but we have to think that the inhalation of bacteria can also be by aerosols. It can be also, and this is more rare also, percutaneously if there is infection through skin, abrasion, or inoculation. This is the population at risk, which is especially the people taking care of animals, veterinarians, abattoir workers, meat inspectors, lab workers, the people who are in contact. and less frequently hunters, travelers, and consumers of dairy products. So you can have contamination from the animal to the human. And the contamination from the animal to the human is a direct one with infected animals, cutaneously or aerial, but it is also indirect with ingestion of contaminated milk or milk product. It can be from human to human, and you have by sexually or ventriculoperitoneal, intrauterine, or by breastfeeding. The professional one is a manipulation of Brucella culture in laboratories, and you can have it also in the veterinarian or the stock breeders. How we go to this physiopathology or the pathogens of the disease? After the contamination, you will have an incubation of days to months. There is the acute phase who will be septicemia 1, and you will have the fever, the first installation of the fever. The subacute presentation is with secondary lesions, and you can have a chronic phase with after 1 year of contamination. This can be multisystemic also as a disease, and this is very important. One of the person who worked a lot on neurobrucellosis is our friend and master, Professor Shakir, and he was one of speaking about the direct mechanism going from endotoxin and cytokines, and this release is responsible of direct involvement of the nervous system. The indirect one is the immunoallergic reaction or cross-antigenic reaction, and this is also which will lead to autoimmune reaction and demyelination. If you see the manifestation of the disease, you will see that any system in the organism can be involved in brucellosis. And you see that here on this case that from the cardiovascular system, the respiratory system, the genitourinary system, the gastrointestinal system, the skeleton, the eyes, but the nervous system, either central or peripheral, can be involved in brucellosis. So all the systems in the body nearly are affected by Brucella. This is to show you that this ondulant fever, where you have, in this case, arthralgia and constipation at the beginning, you can have after later on hepatomegaly, splenomegaly, you can have spondylitis, sacroiliitis, orchitis, and after this new febrile course. And this is very important to know that you can have phases or where the fever is very important, phase where the fever is less, and recurrence secondary of the fever. And you see that the fever is the most important manifestation and the most constant one. The weakness is there. You see that the headache is almost present in the majority of cases. The pain is there, and you have later on a more specific neurological manifestation. The neurological impairment in brucellosis, neurobrucellosis, is a sign of severity of the disease. And we published a paper 10 years ago on the neurological manifestation which are revealing brucellosis. It's in French, it's in the French La Revue Neurologique, and we had a lot of trouble on diagnosing the etiology of for these people. And having a neurological manifestation as the first one is not uncommon. It's not the classical presentation, but keep in mind that it is not uncommon. You can go, and we will see several manifestations, but I have always in mind this patient who come with what was considered idiopathic intracranial hypertension. and it comes to be neurobrucellosis. People will present the neurobrucellosis few years later on classically, and the mean age is 40 years. It's, as I said several times, primary lesion of the system nervous or secondary lesion coming from an initial systemic lesion. For example, people having cardiac location of the Brucella, and after this complication on the system nervous, or having a cross-antigenic reaction, which is autoimmune reaction. The older the patient is, the worse the neurobrucella will be. And the more the disease is in duration, the more it will be difficult to have remission from the neurobrucellosis. So keep in mind that age and duration of disease are elements of to develop neurobrucellosis and to have it more severe, while the gender and the regional distribution are not. So you see that I said that all the systems are affected, but already on the nervous system, all the location can be affected by brucellosis. You can have meningoencephalitis, acute inflammatory demyelinating syndrome, papillary edema and papillitis, inflammatory meningomyelitis, posterior fossa syndrome, neuropsychiatric syndromes, neuropathies, muscular manifestation. But even you can have secondary forms due to compression and for the myelopathies or the radiculopathies. And you can have cerebrovascular syndrome who are due to lesion on the vessels or on the heart. The meningitis is nearly almost constant. I will say that meningitis and involvement of the vestibular nerve is nearly constant. And in our experience, the majority of patients experience meningitis even without huge clinical signs or hear loss. In the peripheral nervous system, we have encountered neuropathies, polyneuropathies, polyradiculitis, and meningoradiculitis. While the form of acute severe meningitis is rare, the chronic one is, as I said, almost there, with headache, with undulant long-term fever, and with chronic inflammation of the meninges, leading from time to time to comminutic hydrocephalus. In the CSF, you can have a rise of the lymphocytes from 40 to 1,400. But the CSF glucose may be normal, while the proteins are, you have rise in proteins and especially gamma globulins. This is one of the cases that a series that also were described in Tunisia more recently, and you see that the meningitis were the presenting feature in 6 cases. Encephalitis in 3 cases, meningoencephalitis in 2 patients, and meloradiculitis in 2 patients. Look at this figure, and you will see that even you have the clinical signs later on, the meningitis is seen nearly between 15 and 25 years of age. So when the disease will begin, the meningitis will be there. After this, you will have other neurological manifestation and more severe. This is a paper from Iraq. This is a paper, as I said, showing that the fever and the neck stiffness are important, and splenomegaly also are frequent in cases of meningitis. One of the most important that we'll discuss later on the diagnosis is the right test criterion. And you see that there's cases that have very huge right serum level on their And you see on CSF. And you see that the characteristic of the CSF from this patient, when you see the cerebral fluid and the white blood cells, that they can range, as I say, from in this case, in this series, the RK series, from the most frequent was 100 to 500 white blood cells and lymphocytes especially. This is a beautiful presentation of how the treatment can act. This is a patient with pachymeningitis, and you see on the top scan that the meninges are very thick, and you see them very obviously. He was put under 3 therapy, and you see after treatment, after some months of treatment, that this meningitis disappeared even audiologically. I will say that you cannot rely always on the this so beautiful evolution on imaging. From time to time, evolution in imaging is not so rapid, and even the patient is better, you will still keep some images for a moment. This is also cases of chronic meningitis, and the title is Neuro-Brucellosis, an often forgotten cause of chronic meningitis. So I repeated several times, never forget meningitis, brucellosis in chronic meningitis. This is a case of hydrocephalus, led by a meningitis, and you see that this hydrocephalus was obvious in this case. And you can have also cerebral brucellosis affecting the brain with acute disseminated encephalitis. You can have fever, impaired consciousness, stupor, coma, intracranial hypertension, and when you make the imaging, you have a diffuse cerebral edema, a confluent and hyperintense white matter lesion, a guanylate enhancement of the basal system, and hydrocephalus. This acute disseminated encephalitis can be lethal. And this is one of the images that you have of a site of such acute disseminated encephalitis. You see here the new fiber involvement. Here you see also a chronic encephalopathy that led to dementia. And in this case, you see that it led even to an atrophy, to the brain atrophy, and a very diffuse, confluent white matter lesion and involvement, as you see, of the hypothalamus. This can lead to differential diagnosis, but it is not MS, believe me, it's, in this case, it's neurobrucellosis. But this differential diagnosis is rare. Even if you have a ring enhancement lesion on the right, on the C+D that you see here, figures. Focal encephalitis can be on several presentations. Hypothalamic, sometimes a tumor-like aspect. We can have even a chorea which can regress after specific treatment, focal epilepsy, narcolepsy, catalepsy. Personally, I didn't saw such case of narcolepsy, catalepsy, but I report what has been on literature. The subdural empyema is exceptional. It was reported in one of the patients of the SFAX series and was lethal. This is a presentation, I said, like cerebral tumor, and you see the on the right the anatomopathology with the brain necrotizing granulomatous encephalitis, with the center is filled with polynuclear leukocyte here and cells. This was a huge reaction, tumor-like to brucellosis. In this case, it came with hemichorea, and you see the T2 weighted MRI images of hyperintense lesion on bilateral cerebral hemisphere. And the examination have shown a right coliform movement. That's the serum title who gave the diagnosis in this case, was published on international an internal medicine journal, and showed that the diagnosis was given with the serum titer of riot, which was 1/160, which is highly significant. Neurobrucellosis can mimic demyelinating disease. I spoke about MS, but you see like this in this case, here, these lesions that can mimic with the heterogeneity, the ring aspect, that can mimic demyelinating disorders. And this case that was published from a Turkish department, the first diagnosis was MS. And that was the lumbar puncture who showed that lymphocytes are more than what, which is very unusual in MS, and they go to specific diagnosis, and the Brucella species were in the CSF culture and blood culture, which makes it sure that we are facing here Brucella. There are rare cases of Brucella abscess and granuloma in the literature. You see on the right of the screen how these lesions are very, very important as a ring lesion here. This is, as I say, case report. It was Brucella Ovis, which was complicated by multiple brain abscess. And you see that these lesions are very huge and nearly took the majority of the brain. But most importantly, you see on the figure this figure that I'm showing. I don't know if you see the pointer, but on the figure on the lower figure, that after treatment this abscess disappeared, and so there was medical and surgical treatment in these cases, and it was necessary on these cases, and it permitted to see the result with a real improvement under both surgical and medical treatment. One of the cases of killing presentation is subdural empyema or epidural empyema. Even if it is extremely rare, it can be fatal, and that's the presentation that you will see, the surgical gesture that you will do if you are not knowing about the cases, and you will find, even by the function or especially by the surgical removal, the cause of this, and the treatment has to be very, very long period on these cases. I spoke about intracranial hypertension. It's rare, as I said. We soon had the patient when we were misdiagnosing at the beginning. And this is also a case from also Turkish groups saying neurobrucellosis that mimics increased intracranial hypertension syndrome. And if you have intracranial hypertension with no known cause, keep in mind, even it is rare, that if there is an exposure, that Brucella can lead to mimical presentation of intracranial hypertension syndrome. Ischemic stroke. Thinking about ischemic stroke from coming from brucellosis will not be easy at all. And you have to keep in mind that you can have ischemic stroke, which can be transient, or constituted stroke. And this is due to vasculitis or Brucella endocarditis with emboli going to the brain vessels. On the other side, you can have intracranial or cerebral or subarachnoid hemorrhage. This presentation is secondary to a rupture of mycotic aneurysm. So you can have ischemic stroke, which is most frequent, but rarely you can have hemorrhage due to mycotic aneurysm. This involvement of stroke and mycotic aneurysm, as I said, thinking about will not be easy. but if you have an exposure, you don't lose anything to make your right test and to see and to search for Brucella even by other means. I spoke about ischemic stroke and intracranial hemorrhage, but the cerebral venous sinus thrombosis is very rare among these rare complications. What you see is an intraoperative image of an aneurysm, and it was clipped and resected. And you see on the lower figure, on the lower slides, that lower part of the slide, that the vessel were necrotized and with thrombotic changes there. The positive culture in these cases is unfortunately less than 20%. And this is one of the problems that you have, that the CSF, the culture is not always positive, and you have to search by all means on neurobrucellosis. But if it is positive, at least you have the final confirmation. One of the vascular manifestations there is the Brucella-related aneurysm that you see on this case, and that had led to a bleeding. This is, as I said, a rare case of cerebral venous thrombosis, and you see on the MRV of the brain that the left transverse sinus is thrombosed, and you see the lesions of the brain on the left of the slide. This is a thalamic infarct that you have, and the thalamic infarct was due on this case to a fresh infarction of, and you see the vessel that it is blocked. As I said, you can have constituent stroke as that I showed, but you can have also an exceptional cause of transient ischemic attack. This is presentation of 4 cases that have been done, and the history of consumption of unpasteurized milk or its product in all of these cases was reported. Nevertheless, there were no systemic manifestation when they developed neurological symptoms. So going to think that transient ischemic attack is due to neurobrucellosis will not be the first thing that you have in mind, but you have done everything, and if you are in unexposed work, keep in mind that brucellosis can rarely present with transient ischemic attack. One fact that I wanted to enhance in these cases is that you have these patients from 20 to 28 years. So the early onset is very important on this. And you see that the CSF culture was positive only in 2 cases here. While when you see the Brucella agglutination test or the Brucella agglutination test on the CSF, you have results which are more convincing on this case. Brucella can also affect the spinal cord. It's a journey of lesion I'm sorry about, but I have to speak about, as I said, it's a misleading presentation, and we have on this course to go through to be extensive on the presentation, even if they are rare. You can have acute myelitis with a flaccid paraplegia or quadriplegia. You can have a subacute or chronic myelitis, which is more frequent, and that we encountered also. This paraplegia can be, you can have motor involvement, sensory involvement, or sphincter disorders. The mechanism is a vasculitis or a spinal arachnoiditis. The spinal cord compression is also possible by spondylodiscs or epidural. This is something also that the imaging will solve easily on these cases. And here you see the distribution of the involvement of each vertebra in spinal brucellosis. You see that the involvement is on the majority of cases on the lumbar stage. And this is important to know. You will have very rarely affection of the upper part of the cervical spine or the dorsal spine, the thoracic spine. The involvement is mainly on L4, L5 vertebrae. This is something that you have to keep in mind when someone will come with pain, lumbar back pain, and you have a this person by his exposure. Okay, this is the intramedullary brucellosis. It's rare, it's controversial. It has been reported after always a systemic brucellosis case. The transmission should be secondary to spondylitis and vasculitis or arachnoiditis. Its primary intramedullary brucellosis is really exceptional, and I don't advise you to think about as a cause of intramedullary lesion, even if exposed person. It's very, very rare, exceptional, and we are not sure it is really the Brucella it is in. There is a blood positive serology, and the imaging is helping on the diagnosis. This is a kind of lesion that you can have. You see on the yes, that it can mimic an inflammatory disorder, and you see on these cases that even the vertebra is not on good shape. And the same lesion was located on the right side of the spinal cord, intramedullary and extending to epidural space. So on this case, as I said, the contamination through the vertebra should be discussed on this case. Personally, I never encountered this presentation. The spondylitis, which can be harmful by the lesion of the vertebra or by the abscess, has to be known. It is, as I said, especially on the lumbar region. You can have fever, back pain, and anorexia. You can have also a positive Lassex test. Rarely it goes to the coda equina or you have a spinal cord syndrome. The diagnosis is fine, especially in elderly patients with back pain and in endemic areas. The imaging will lead you to the diagnosis very, very rapidly. This is another image of Brucellar spondylitis, and you see on in this case the marked enhancement of the disc and the vertebra and plate after gadolinium administration. You see also on the image on the right that you have an enhancement of the interior surface of L3 and L4 vertebra extending through the adjacent L3, L4 disc space after gadolinium administration. And this is important that you see this image, you have this, and you see that you have involvement of this vertebra, as I said, on L3, L4 most frequently.
Riyad, I'm sorry to say, but we have 1 hour now, and I think we should come to a conclusion because we have some questions also. Sorry.
Okay.
Sorry.
I thought that there was 45-minute presentation. Okay.
Okay, wait, please, now if you take more time, that's fine, but it's,
okay.
I think it's according to the time. Thank you.
I'll go rapidly. I'm sorry to having been so, because I'm so passionate when I speak about neurobrucellosis. This epidural spinal brucellosis also shows the same presentation of having an abscess which is epidural. This is the same image of the infection in the area between dura and subarachnoid. I cannot go, Wolfgang, you are a peripheral nerve like me person, nervy person. We cannot not speak about peripheral and cranial nerve and muscles in brucellosis. It can present like a polyradiculoneuropathy clinically, but it is a meningoradiculopathy. When you will make your lumbar puncture, you will find some modifications. But you can have also modification on cranial nerves. The one I always speak about is the 8th nerve, with often bilateral hearing loss, even before treating patient, even before giving streptomycin and other treatment. The good thing is that when you begin the treatment early, you have a good response. And you have one patient on 5 will have kind of peripheral neuropathy, except the 8th nerve I said, which is constant. The cranial nerve involvement I spoke about. I will go rapidly on this. The polyradicular neuritis I repeated is made on the diagnosis of positive serological tests. And you can have on EMG prolonged F wave, decreased nerve conduction velocities, and thinking about polyradiculitis when the patient is not known with the diagnosis will not be easy. If you do an MRI, you will have an enhancement of the lumbar nerve root, which can lead you to a more precise diagnosis and to think about Brucella if you don't think about it. The myositis is rare but has been declared. What is more frequent is frequent diffuse myalgia. This is something which is more frequent. The real presentation of myositis of rhabdomyolysis is more rare. It can be also congenital, and there is no thing on neurology to enhance a lot on this. As I said, the diagnosis will come from your presentation, from your clinical signs, and mostly the biology of isolation of the bacteria blood culture CSF. The PCR study is sensitive and specific, and this is an important fact that you have to find a lab who will help you on this. And the serological proof is very helpful. We arrived in Tunisia, for example, to the PCR very late, but now we can afford to do it. And we were very, very accountant on the serological proof of infection. It's a group of arguments. It's the presentation, the CSF, if it is positive, and it's good, it's the serological diagnosis who will be helpful. And we did all this algorithm that you see in right on this to help having the diagnosis. I said that it is a mimical. I spoke about a lot of disease, but one is important in our region is tuberculosis. It's, if it is not tuberculosis, think about brucellosis. And this is something that I should repeat and repeat again. Going to the treatment, you have, and this is a very important chapter on this pathology. The antibiotics are the cornerstone on this disease. For me, and what we are saying is for neurobrucellosis, we are advising to have 3 therapies. And it has to last at least 6 weeks. And this is from cyclins, rifampicin, streptomycin, and all these drugs that we have and that are available in all over the world, I think, are the first choice for neurobrucellosis. Should we give corticosteroids? We have to think about. It is discussed in some cases when the situation is, I would say, dramatic, but there are reports also that you can have worsening under corticosteroids. So it's a discussion issue on this. You can go to surgery with laminectomy of removal of granuloma. I said that the Brucella is an intra-organ cellular coccobacillus. So you have to give this antibiotics to go through, can go through the cell, and you have to give it for a large period, less than tuberculosis, but you have to go to several weeks, and you have gone on 3 months in some patients, and more even, and especially if you have a clustering of the lesion, which is blocked in, for example, when you have lumbar lesions and you cannot afford surgery. When you have children more than 8 years and adults, the first choice is doxycycline. Gentamicin can be used, but believe me, with the problem of the hair loss have to be in mind on this case, especially for gentamicin. In second choices, you have rifampicin and doxycycline. And as I said, I advise for my part, 3 therapy. When you have meningitis, people go and it is acute meningitis or it is a severe meningitis. There are people who have gone even to more than 1 year of treatment. and the treatment was continued until the CSF were no evidence of still having Brucella. Even if you have cessation of treatment, you have to search of the agglutinins that should be followed on the serum. If you have less than 8 years, the risk of relapses is less than 5%, and you have to give the treatment for 6 weeks, as I said. For chronic brucellosis, the triple antibiotherapy is important, and this is what I repeated 3 times on this talk. For pregnancy, it's a challenging problem because of the risk of this antibiotherapy. You can begin with the monotherapy. You can have B therapy with rifampicin, and the use of these drugs should be mostly on the end, by the end of pregnancy, to avoid having childbearing problem. Other indications are the ischemic stroke I spoke about, the cerebral venous thrombosis I spoke about, anticoagulant. There is nothing which is specific. For the polyradicularitis, the dual or triple combination, more than 3 months, and the rehabilitation and the good treatment will be if the diagnosis is made early. The surgical intervention is rare. It's when you have a mycotic aneurysm, if you have a subdural hemorrhage, or if you have a spondylitis. And at this point, you have to go to a surgical treatment, and it is very helpful on this case. But the most important thing is the prevention and control. We have to educate our patients. And I always, when I finish my talk, say that when I made the diagnosis of patient, which was very difficult, of brucellosis, he was very happy. We treated him. He was good. And when he came to the consultation again, he came with a gift, which was a raw milk and cheese. So he didn't understood that the problem was on this, and I didn't make, I would say, my job as it is, and to give the counsel and the education. And we have to give it from the veterinary part, but also from the medical part. This is something that is not constant in time. You can solve the problem. We solve it in the year 2000, 2010 in Tunisia, and it came again now, and it is coming more and more endemic. So you think that you have solved the issue. If you don't solve the issue from the animals part, it comes to the humans after. Vaccination is very important for the animals. The neurobrucellosis is rarely fatal, but relapse can be seen, I said, in 5%. And it's always when you fail to complete treatment or you don't do surgery when there is a block that you have to put out. I come, Wolfgang, to conclusion. Sorry to have been more time. You have a large spectrum of presentation. It's a mimicking pathology. It's not rare. It's seen in our countries. And you have to think about and to keep in mind when we don't see the diagnosis, obviously. There are different mechanisms that go on, direct and indirect. And if you have to make the diagnosis, you have to have an argument beam. You have to have the epidemiology, the clinical presentation, the laboratory finding, the imaging results, and the evolution under treatment. And you have to exclude other diagnoses. The early is the antibiotic, the better is the prognosis. The more prolonged is it reasonably, the less you will have relapses in this case. And don't hesitate to discuss with your surgeon colleague when you think that the removal of an abscess or compression will be helpful. With this, I thank you, and I hope it was enough clear and I didn't take much more time than needed. Thank you so much.
Thank you, Riyad. This was systematic, illustrative, and it showed this huge spectrum. And I think one gets carried away with the presentation because it's so full and it has so many items. How much time do we have for questions now? We have several questions. Meshram, how much time do we have?
10 minutes.
Okay, very good. So I start off. The first question is, what is the diagnostic SAT agglutination titer? So SAT, I suppose, means serum agglutination titer, I suppose.
It depends on the techniques, in endemic zones, you have to have a title that we have on, as I presented, less than 1 on 80 on our population, that we have the title. I don't know, for example, in India, Meshram, what is the title that you have on this? It's less than 1 on 80 on our serum agglutinin test. Because
I'm also not aware about the titers.
Okay, and the title in endemic region can be even 1 on 320, but we in our country use 180 to 160, depending on the endemic region where it comes.
Okay, thank you. The next question is also difficult. What is the difference between MS and neurobrucellosis demyelination?
But in the neurobrucellosis demyelination, as I said, this is an immunoreaction, and you have antibodies that will attack the myelin. On the MS, we don't know who is the trigger and who is the antibody who triggered the demyelination. The presentation is not the same even when you see it. It has not the periventricular presentation when you see the MRI. It's not, you have this huge lesion, demyelinating lesion, but not on the presentation that it usually on MS. It will take more the U-shaped fibers, and it will be not leaded by, I said, a known anticoag, but a known one, which is driven by brucellosis.
Okay, thank you.
Yes.
So I think the question was, it would be my interpretation, if you look at an MR scan and you see demyelination, is there any hint it could be brucellosis? And usually one thinks it's MS, of course, but is there any specifics?
As I said, on the MS, you have the periventricular presentation, which is more that we know, and that when we see it is confident you have this lesion which out on you, while the lesion of, as I showed in brucellosis, are more important, as I showed on this presentation, for example, and especially when you have such demyelination, you have a sign that you don't have in MS Wolfgang, which is the fever. And another point which is important, which is on the CSF, when you have this demyelination, we will have also white blood cells that give you the difference, which are by far more than 50 when you have such lesion. So the presentation on MRI is not the classic one of MS. The fever in MS is very rare, and especially when you do your lumbar puncture and you find cells, you know it's not MS.
Okay, that sounds very convincing. Thank you. Another difficult question. What is the difference between tuberculosis and Brucella spondylosis?
It's one of the most important things is that the disc is usually eaten in the tuberculosis with the destruction, huge destruction of the vertebra, which is not the same case on the brucellosis. What have you seen on this this presentation? But sometimes you have to go to the histology, you have to go to the bacteriological study to make the difference. But the one in our experience, the most important is that you don't have the collapse that you have on the what we say the mal de pot that we have on tuberculosis.
Okay, thank you. Another very interesting question is, in places where culture is not available, in chronic meningitis cases not responding to other treatment, do you advise on empirical treatment?
I'm sorry.
Okay, in places where culture is not available,
yes,
and you have a case of a chronic meningitis which does not respond to any other treatment, do you advise on empirical treatment?
I will make it like this. Usually, if you don't have the diagnosis from the culture. You should have the right test on the serum, the glycine, and you should have the, if you don't have it, you should have, which is very frequent, CSF reaction having, if you are on a case where you don't, I will go to treatment because if either tuberculosis or brucellosis. It is what I said, the culture, I will not to repeat it, is the gold standard, but it is not constant, and you can find, you don't find cells on culture, so don't think it's not brucellosis, it may be. This, as I said from the beginning when I spoke about the diagnosis, and I want to repeat it, Wolfgang, the clinical presentation, the imaging, the biology and the serum, the CSF, and especially the sex. It's all these arguments that led us to make the diagnosis on our cases, because we were able to have a CSF culture until recently, and PCR.
Thank you, Riyad. That's very clear. There's one question: what is the 2ME test? And it says here, Raj Shakir will answer that question. Could Rad answer that question, what the 2ME test is? It says here.
Thank you. It's nice to hear this, Riyad. Thank you very much. Mercaptoethylene. Hello. It's 2-mercaptoethylene test, and it was a test which preceded serum agglutination test, and it's still very useful. I think now ELISA tests have surpassed the SATs. So one more question, which is important and was half answered, was that sometimes the titer is so high, you need to dilute the serum before it becomes positive. So one more question about lab diagnosis. Culturing Brucella is difficult.
Yes.
You need to culture it in a certain temperature, and the lab has to be very much, so it is difficult. So mercaptoethylene is an older test. It's still very useful. Thank you.
They're going better now with the PCR.
Thank you.
Okay. Can I use 2 more questions? Meshram, do we have time for 2 questions, important questions? One is...
We can take 2 more questions, yes.
Okay, 2 more questions. Can steroids be used in brucellosis, meningoencephalitis? If you can, for how long and how much dose do we need? So steroids in meningoencephalitis, is it applicable?
Yes, it is. You can use it, and I will also ask the Rad experience on brucellosis, because he is the hugest one. It's something which is contested. When you use corticosteroid, you can have, and I see that Manji also is there to perhaps speak about, the use of corticosteroid is something that it is contested, and we think that in some cases it can lead to an aggravation of the situation. I will recommend it. If there is an edema, and I will use it for a few days and we'll stop it, because we are not very convinced that it will help the situation. What do you think about Rad?
Yes, thank you. I agree with you, and I think the figures are 3 months that we have used in the past, but this is arbitrary. There are no really standardized studies that we have. We use for 3 months, especially if there is, the worry is when there is hearing loss. And there's one thing to mention: the most susceptible joint for brucellosis is the sacroiliac joint. The SI joints on both sides get affected for some reason. There is predilection. Some people say it's the venous supply. Some people don't know. But in many years, for many years, we used to do bone scans looking for the SI joint involvement. 3 years for prednisolone, 60 milligrams, and reducing the dose and seeing the clinical response. And this is arbitrary. It's not dependent on a randomized clinical trials, etc. Maybe Hadi, you want to say something about that?
Right. So in 23 years, I've had one case of neurobrucellosis here in London. And the interesting thing was, as you pointed out, the initial serological tests were negative because the lab missed the prosome phenomenon. And it was only when they had to repeat the test that the diagnosis came through. So I think that's a valid point. But my experience, I'm afraid, is limited in neurobrucellosis in London.
Okay, thank you. So last question.
Just to comment on corticosteroids, we used once only the bolus, and we were very reluctant because we were thinking that we can have a shock reaction on this, but it has gone well. It was a malade from chocolate.
Okay, we had last question for you. Why is anticoagulation controversial in the cerebral venous sinus thrombosis?
Why the anticoagulation is controversial?
Controversial in the cerebral venous thrombosis, sinus thrombosis. Sorry.
That's something that has been discussed from even Marie-Germaine Boussert from France, and discussion about using anticoagulation in thrombus venosus from infectious origin. But what came after this and what it is convincing is that we have to put on the good antibiotic therapy, but the anticoagulation will be helpful. What there is that if you have aneurysm or mycotic, that you can enhance the risk of bleeding. But what it's come is that you do the antibiotic therapy, the anticoagulants, for my side, I will use them because the effect of anticoagulants in thrombovenous thrombosis is indisputable. The risk is to be calculated if you have aneurysm of risk of bleeding.
Okay, thank you, Riyad. I think this finishes the question answer session, and I hand over the chair to Haji to continue with the case.
Thank you, Wolfgang.
Thank you, Riyad. Again, it was beautiful, and this was a good example of teaching and large content in a short time. Thank you.
Thank you so much.
Thank you, Wolfgang. Thank you, Riyad, for your presentation. So thank you, Professor Meshram and the trustees of FINE for these meetings, which are very educational. So we come now to the three case presentations. You have 20 minutes each. And if the previous cases are anything to go by, such as the Racimo cysticercosis and the SSPE from last week, and I think we're in for a treat this afternoon. So the first presenter is Dr. Ashish Buttada. Are you there, Dr. Buttada, to present your case?
Yeah.
Great. So can you present in about 15 minutes, and then we can have 5 minutes for questions?
Yes.
And will we have a chance to have a discussion of your case before the final diagnosis, or will you go straight through?
We'll have some questions in the end, sir.
Okay.
And
Okay.
Dr. Satish Khadilkar is also there. He can make a comment.
Oh,
He
yes.
has also seen the patient.
Okay. So we have a panelist who can comment as well. So why don't you do your case, Dr. Buttada? Thank you.
Thank you, sir. Start with the case. Is my screen visible to everyone?
Ashish, the screen is visible, but your voice is not coming too well.
Okay. Am I audible now, sir?
It's coming and going, like in between, it's not audible.
Speak loudly, Ashish.
Maybe you can go nearer the computer. Okay, let's try.
Am I audible now, sir?
Yes, yes.
Little better.
First of all, I thank Dr. Khadilkar sir and Dr. Meshram sir for giving me opportunity to present the case here. I'll start with the case. It's a case of gangrene. We had a 50-year-old female. She came to us with paresthesias in soles and soles of both feet. And then over the period of 1 month, she also developed foot drop. And 15 days later, she developed paresthesias in hand and weakness of right a weakness in right ulnar nerve distribution. So basically, she had developed ulnar neuropathy, and she also had trophic changes in her upper limb. She had joint pains. So basically, lower involvement and ulnar nerve involvement. The diagnosis of mononeuritis multiplex was made on the clinical ground. On examination, she had trophic changes in right hand. Thickened nerves were present. Right ulnar, both common peroneal, superficial peroneal, and sural were thickened. So basically, it was multiple nerves involvement, proprioception, and deep tendon reflexes were normal in this case. And there were no hypopigmented patches after screening, even back and the abdominal and chest region. So basically, we have multiple etiologies of mononeuritis multiplex, like infectious disorders or autoimmune disorders, tumor, etc. And we have multiple causes for thickened nerves as well. Like most common is leprosy, and other few like CIDP amyloidosis. Uh, in India, the most common cause of mononeuritis multiplex within the nerve is leprosy. So our suspicion was leprosy here. Since there were no skin lesions, we were thinking of pure neuritic leprosy.
Dr. Ashish, sorry to interrupt, but your voice is not coming out clear.
Now,
Try using earphones if you have.
just
Satish, maybe you can talk about it till then.
So maybe we can, while we're getting that sorted out, any comments, Satish? I mean, one of the questions in somebody with mononeuritis multiplex, one of the things is that the reflexes were present, which always raises some queries about the diagnosis in terms of differential. And I agree with the causes of thickened nerves. And if you use various sieves, you use a sieve of mononeuritis multiplex, then use a sieve for thickened nerves, and then you come to reflexes being present in neuropathy. There aren't many in the differential diagnosis.
Yeah.
So do you want to make any comments while Ashish is
I mean, absolutely. I think reflexes being intact would actually surprise you in the setting of a neuropathy. But amongst various causes, leprosy would be one, where the reflexes will tend to go away later because it affects the superficial nerves and also keeps the proprioception intact. So that may be another pointer. But I think as time goes by, the reflexes do go away in leprosy as well. So yeah.
And while we're discussing it, I actually sent an email to Sudhir. I was reviewing a paper about central nervous system signs in leprosy.
Yes.
Is that something you've come across while we're discussing this? My own education.
Yeah, actually we ran a project some time ago where we did MRIs of the brain and spine for 100 patients of peripheral nerve leprosy. And actually we came across very, very few people in whom there were CNS changes. But there were a few where there was a leprous ganglionitis. The ganglia were actually inflamed and took up the dye on the MRI. And two patients in whom there was a spinal cord signal in the same segment where the ganglion was inflamed. And the characteristics of the signal on the MRI were like tuberculomas. So there were granulomas in patients of proven leprosy and ganglionitis. So I think we know that it goes to the ganglia. We know that it also goes to the adjacent spinal cord segments. There is also some demonstration that the facial nerve nuclei have been shown to be affected by leprosy on MRI scans. The question is whether it also causes granulomas in the brain. I am not very sure about that, but there is a Japanese series of some 20 or 22 patients where they have shown the DNA of the leprobacilli with the PCR test within the brainstem and also in the cortex. So it's possible it probably goes much more wider than we commonly know it to, the way it is.
Yeah, thank you. Ashish, how are you doing? If not, let's any other comments about this case of leprosy? So without any skin lesions.
Yeah, that's the second point, I think, in the case.
That, but I think certainly I've had one case here in London where we had a similar presentation, no skin lesions. I sent the lady to our only leprologist in the country and was told this is not leprosy. So we did a biopsy, as I presume, which is what Ashish is going to show us. And that turned out to be lepromatous leprosy. Was there much pain? Did she have much pain in this?
No, it was a reasonably, I mean, there were sensory features like paresthesia, but not actual pain.
All right. Ashish, how are you doing?
I just wanted to ask Satish and Hadi. Generally, a mononeuritis multiplex, you will get maybe, let's say, peroneal or radial or something. So the sciatic can get affected, of course, but rarely. And therefore, ankle jerk is often spared. So would you, I mean, how would you explain ankle jerks or bicep jerk getting absent in leprosy? It would be very unusual for those nerves to get affected. In fact, if you get that, I would look carefully at the diagnosis again and see if there's something else, maybe diabetes, something or nutrition.
I think so. This point is in general well taken, that you should see good reflexes at least in the beginning, but it seems to depend on the length of the illness and also the type of leprosy. Like in lepromatous leprosy, when the bacillary load is very high, there is a proportion of patients who get a standard pansensory, so to say, a neuropathy with motor features, and they are areflexive. So they are like any other neuropathy. So even though it starts with superficial nerves, in some people related to the immunity of the host, of course, it becomes much more. So, and these are usually multibacillary and on the lepromatous side of the spectrum.
Okay.
May I just ask, sorry, the nerve thickening, was this homogeneous or was it, let's say, at certain spaces? I mean, if you do I mean, how did you assess the nerve thickening? By touching or by ultrasound or by MR?
Yeah, actually we use all three techniques, but ultrasound is much cheaper. And of course, clinical examination is the first one. And skip lesions and the beading are two features that I think strongly go towards leprosy. That there is a thickened portion, then there is a gap, then there's another thickened portion. Sometimes even those thickened portions are tender. So skip lesions, multiple lesions, and strong beading will clinically favor. We do use a lot of ultrasound now, and because it's so much easier to get and comparatively inexpensive. And there are also MR neurography information on that. So all three techniques, absolutely.
I mean, I always tell our residents to get into the habit of palpating nerves. It's a good clinical sign. And it's astonishing when you ask them to feel the superficial radial, the look of blankness that comes on and panic. It's quite entertaining, really. Ashish, how are you doing? Great. Okay, so why don't you carry on?
Yes.
Yes, you're doing fine. Let's crack on.
So basically, we went ahead with the investigation. ESR was raised, and other investigations like CBC, liver function, renal function were normal. Autoimmune workup initially, like vasculitic workup, was negative. RA factor, hepatitis B, hepatitis C serology, HIV serology was negative. We took split smears from earlobes and supraorbital regions, which were negative. And nerve conduction, of course, showed multiple mononeuropathies. And here we didn't have hypopigmented patch. So we decided to go ahead with the nerve biopsy. Basically, these are a few common indications where we consider nerve biopsy, like vasculitis, sarcoidosis, pure neuritic leprosy. Here we were suspecting pure neuritic leprosy, and we chose sural nerve for biopsy. And here, what we got, this is on the sural nerve biopsy, we got this lepra bacilli. There
the fight
was
Faraco. It's the
yeah,
fight
yeah.
Faraco.
It was fight Faraco strain, and lepra bacilli were positive on this image. We can see it clearly.
Yeah.
There was marked perineural fibrosis, mild lymphocytic infiltrate. We could see two vessels showing lymphocytic vasculitis, and stains were positive for lepra bacilli. So now here the diagnosis was clear that we were dealing with leprosy. We started patient on rifampicin, dapsone, clofazimine, and we also started patient on 60 milligram prednisolone to begin with, and gradually tapered over next 3 months, and she was doing well. After 1 year, we stopped multibacillary treatment, and there was a new problem after 1.5 years after her first symptom. Her neuropathy was recovering during this period, but she developed dry gangrene of toes of left foot, and her pulsations, posterior tibial, dorsalis pedis, were absent. She still had bilateral foot drop and weakness in right ulnar distribution, but no new nerves were involved. So this was the gangrene. So what we thought, what is it a new problem altogether, or it's related to her old problem? Is it Lucio phenomenon? Is it secondary to thrombotic syndrome like EPLA, which can be primary or secondary to some of the infections? And in leprosy also,
sorry,
yeah.
What's Lucio phenomenon? I'm not aware of that.
Sir, basically, it's vasculitic involvement in leprosy, where there is sudden worsening of skin lesions and necrotic patches, especially over the lower limbs.
Okay, thank you. Thanks.
Yes. Secondary thrombotic syndrome, whether it is vasculitis, is it infiltration of vessels with lepra bacilli? We don't know. So we went ahead with investigations. This time ESR was 87, ANA was positive, and anti-cardiolipin antibody were positive. And we had repeated anti-cardiolipin antibodies after 2 weeks, 2 months, and again they were positive. Some other workup for prothrombotic workup like ANCA, homocysteine, lipids were okay. Her lupus anticoagulant was negative. Protein C, protein S, factor V Leiden mutation were normal, and her echo was normal. Color Doppler showed absent flow in dorsalis pedis artery with diffuse intimal thickening in all the arteries. Vasculitis. So we thought it to be vasculitis due to EPLA syndrome, secondary to probably Hansen's disease. And when we went through literature, EPLA syndrome can occur in multiple infections like HIV, syphilis, hepatitis B, hepatitis C, tuberculosis, leprosy, infectious mononucleosis. So any of these chronic infections can lead to disimmune state and EPLA syndrome. So we started patient on steroids again and followed by oral prednisolone, and we started oral anticoagulation also. She, however, required amputation of the gangrenous toes. 6 months later again, she developed gangrene at another site in her right little finger. We restarted steroids, and then there were no progression of the gangrene. We continued the patient on low dose steroid and warfarin. So here little about APA syndrome. It's a heterogeneous group of antibodies which have been reported in the setting of autoimmune disease or infections. Antiphospholipid syndrome comes with thrombosis, recurrent fetal loss, and or thrombocytopenia. The syndrome occurs in its primary form or secondarily in association with other autoimmune disorders. So there is a relation between infection and autoimmunity, and there are multiple articles available about relation between infection and autoimmunity. So now about leprosy and APLA syndrome.
So we'll have to rush through this a little bit. We're running out of
Yes,
time.
sir. Yes, I'm about to finish the presentations.
Thank you.
Yeah, in infection, often these antibodies are transient and disappear after the treatment. First, in leprosy, it was described in 1979, and it's variable from 2 to 60% of patients' antibodies can be positive, and antibody positivity can be symptomatic or asymptomatic. So basically, there are some unanswered questions in my mind regarding leprosy. What dose would we use and duration of steroids initially? The need for repeated courses of steroids in symptomatic cases, role of anti-leprosy medicine even after 1 to 2 years of course, and what is the literature available regarding resistance and relapse studies. Thank you.
Excellent. Thank you very much. That's a fascinating case. So is there any literature on leprosy and how strong is this association? Because as you said, was this simply one diagnosis or two diagnoses?
Yeah, I think that's one of the questions in this case, because it seems to occur very uncommonly. So one doesn't know really what is the causal relationship, and the case actually opens up more questions than giving answers.
And
one
the
of them
gap is very long, wasn't it?
Is pretty long. So how is the causal relationship? One would have believed that with the antibacterial therapy, the leprosy was improving. Then why? What was the mechanism by which this syndrome got manifest? How does it relate in terms of pathophysiology to the infection? But there is a documentation of similar cases from time to time. So there is some loose relationship between the two. What we couldn't identify is what's the exact mechanism. And that raises these questions. It also brings one more point as to how long does one treat with the antibacterial therapy? How long does one treat with the immunological therapy? Particularly the immunological therapy in leprosy seems to be quite arbitrary, and people follow various regimes. Here we had to give one course, then the second course, then the third course, and then the disease stabilized. Now we don't know whether the steroid stabilized it or naturally it stabilized. So we thought we'll show this case just to bring out the complexities in the diagnosis of leprosy and what all different things it can do.
No, very interesting. Was there any relationship to any, the leprosy reactions, when they change from one aspect to another? Whether this could be a factor?
Yeah. Now this particular lady didn't get a reaction, so to say, in her history, but this could be something unusual of that type of immunological change in the vessels.
Yes, a manifestation of that.
Yeah.
And like all these things in medicine, it's all about association or causation is very difficult. If you try and apply Bradford Hill's criteria, it's very difficult. Ashish, thank you very much, and Satish for the excellent case. So let's go to the second case, which is Dr. Abir Goyal. Are you ready, Dr. Goyal, to present your case?
Yes, sir. Yes, sir. A very good evening, everybody.
Excellent. Good evening.
So you can see my screen.
Yes.
Yes, your screen is visible.
Okay.
Okay.
Thank you.
So I shall be presenting a common encephalitis, which we very commonly miss also, and the lessons learned from that. So presenting the case details, we had a 55-year-old female who had presented to us with the chief complaints of fever since 7 days, drowsiness since 2 days, and altered sensorium since 1 day. Now, at the time of admission, her vitals were stable. She was afebrile but stuporous. Her pupils were bilaterally equal and reactive to light, with no signs of papilledema, though necrosis was present. And the thing to see here was the deep tendon reflexes are absent bilaterally, with bilateral flexor plantar responses. She was immediately intubated and put on mechanical ventilation, and routine blood investigations were sent, which were normal. So how do we approach this case? What are the substrates we have? First one was fever. So let us think about the infectious cause. Second was altered sensorium. So probably an infective encephalitis. Third was absent DTRs. So probably we can think of polyradiculopathy. So the three substrates we have is an infectious encephalitis with polyradiculopathy, which was acute onset. Now with the possibilities of these substrates, acute onset, rapid progression in an endemic area like us, we have to think about one of the possibilities as rabies, which would be a very strong possibility. Though we cannot really rule out the other acute infectious encephaloradiculitis possibilities, West Nile fever being common in the Western countries, not so commonly seen in India, enteroviruses, and other viral infections like Epstein-Barr, HSV2, and other infections. The same substrates, if had presented in the subacute or chronic manner, we would have definitely thought about tuberculosis, HIV. Though not really applicable in these cases, but for the benefit of our colleagues, we can also think about non-infectious causes like porphyria, channelopathies, or even paraneoplastic syndromes. So in our case, we have infective encephalopolyradiculopathy. So in retrospect, with these possibilities, we went for the history and we had a Ehrlich history of dog bite, category 3 on face 1 month back. She definitely had received rabies immunoglobulin as well as anti-rabies vaccine as per the schedule in adequate doses. So we went ahead with the MRI on day 1 itself. And what we can see here is a T2 flare hyperintensities in bilateral basal ganglia, bilateral thalamus, which was also showing diffusion restriction in bilateral thalamus. We can clearly see these T2 flare hyperintensities in the similar areas, also involving bilateral insular cortices, bilateral medial temporal cortices, midbrain, the upper pons extending till dentate nuclei of bilateral dentate nuclei. We went ahead with the CSF examination, which showed total count of 54 cells, which were lymphocyte predominant. Protein was 101 milligram per deciliter. Glucose was normal, with ADA being 4. Keeping our possibilities, we went ahead with the detailed CSF examination, which showed a normal, a negative for tuberculosis, panviral PCR, VDR, and other infections. We did send for the CSF and nuchal skin for rabies viral RNA, which came out to be negative. But still, in the presence of a history, the history of dog bite, the typical history, the rapid progression, as well as the MRI changes, we had a strong suspicion of rabies encephalitis. So we had started an empirical treatment based on the Milwaukee protocol. So we added injection midazolam and ketamine, and with that, we started her on tablet amantadine. We did add an injection interferon as an antiviral agent intrathecally to this Milwaukee regimen. So how did this progress further? Now, day 7 of the stay, patient had dysautonomia with BP fluctuations, which was further dealt with increasing the dose of ketamine as well as midazolam. And day 15, after we tapered off the sedation, the GCS had improved from baseline E2V1M1 to E2VT-M3. Day 17 onwards, she did show hyponatremia polyuria, which was which we thought to be secondary to cerebral salt restrict syndrome. So we had again dealt that with a adequate isotonic fluid replacement. And by day 20, her GCS had further improved to E4VT-M3. So on day 25, that is on the 4th week, we again sent her CSF, which again came out to be negative for rabies viral RNA. But when we check for the antibody titers, as we can see, there was a significant rise, right from 256 to 2048, about 10-fold rise in titers between the two samples, which was definitely suggestive of rabies encephalitis. So irrespective of the vaccination, the presence of this 4-fold rise in CSF is suggestive of rabies encephalitis. After a month, she was shifted to TPS ventilation with a similar GCS of E4VT-M3. But on day 43, she had a fall in sensorium with a fall in saturation showing with the left lung opacity in lower zone with subsequent septic shock. And unluckily on day 47, she died due to septic shock and hospital-acquired pneumonia. So in the end, what did we learn from this case? What were the gaps in management, diagnosis, and the treatment? I'll be covering this in the next in these four headings in the next subsequent slides. So whenever a patient like this comes, the first and foremost thing is to watch out for any history of improper post-exposure prophylaxis. So it's a duty to first see whether the patient was classified as per the WHO criteria into the right category. Second, what has been seen as whether the patient has been given a proper wound management. Now this sounds to be a very simple, a very common thing, but this is also one of the most neglected things. So we have to see whether the patient's wound was washed properly with the running water, followed by chemical disinfectant. Now there's certain things which I would like to impress upon. For example, PEP of an immunocompromised. Now for an immunocompromised, even in our field, when the patient is on a chronic steroid therapy, they cannot mount a memory T cells. So they cannot really mount an adequate immune response. So for them, both category 2 and 3, it warrants an immunoglobulin as well as a vaccine. Rabies immunoglobulin, a few points about that. As already suggested, it has to be given in category 3 exposure. Administered as soon as possible, but not after day 7. They do not let the vaccine take the mount immune response if given after day 7. Local injection should be given around all the wounds. We should not leave any wound, especially in case of multiple wounds due to the dog bite. Do not administer in the gluteal region. Due to the fat, there won't be any absorption of that rabies immunoglobulin as well as for the ARV. So do not administer in the gluteal region. Finally, there has to be proper full course of anti-rabies vaccine as suggested by the National Rabies Control Program and WHO. So when we went ahead with what were the causes for failures of post-exposure rabies prophylaxis. So here Henry Wild, he had seen, done a case series of 17 cases in which he had seen that a true PEP failure was due to the lack of the immunocompromised illness, lack of identification of the immunocompromised illness. Or maybe the vaccines and the immunoglobulins which are given out of the low potency, maybe probably because of lack of keeping them in a cold chain, or maybe because of the lack of quality. Third is the reliance of intradermal more than the gold standard intramuscular regimen. The other possible causes being the wrong or the no administration of immunoglobulin or vaccine, maybe by the improper classification of the patient, or the inadequate wound care. Second is when to suspect rabies. Now we have a patient who has come with acute encephalitis. Now when do we suspect rabies in that? One, when we have it associated with psychotic features or movement disorders. Second, the patient is showing rapid decompensation or concomitant acute flaccid paralysis or the presence of paresthesias, fasciculations and autonomic instability, especially on the bitten limb. So as suggested, it's not only the encephalitis, it's not that rabies only present as encephalitis. It can also present as a paralytic form, which is often confused with GBS since both present as ascending paralysis, as ascending pure element paralysis. So what are the points that helps us differentiate that? Severe paresthesias, fasciculations, and mixed edema in the extremity with bite, rapidly progressive course with eventual CNS involvement, and fever being common during the prodromal phase. Also, more autonomic dysfunction is seen in the paralytic rabies rather than GBS. So these help us to differentiate it from GBS. Further, once we have made a clinical impression, we can go ahead and see the different types of MRI findings which we can see in rabies. For example, as seen in this case, we can have the T2 flare hyperintensity in the basal ganglia or the thalamus. We can also have the similar T2 flare hyperintensity as a longitudinal hyperintensity in the spinal cord. And if we go ahead, especially in the paralytic limb, the limb which was bitten before, we can see the T2 flare, the contrast enhancement in the ipsilateral plexus, be it the brachial plexus or the lumbosacral plexus. Now, one important thing in rabies is that since in the pathogenesis, if we see, it does not really cause a neuronal destruction, neither it causes a cytotoxic damage. So why is that important? Because all these changes in the MRI are not associated with significant diffusion restriction or contrast enhancement, which helps us to differentiate rabies from its differentials. For example, in Adam, we have more involvement of white matter more than gray matter, but in rabies, we have predominantly gray matter involvement. In other viral encephalitis, we have again the different viruses involving the different particular areas of the brain, but with again the diffusion restriction and contrast enhancement, which is not seen in rabies. Similarly, another differential of this would be a metabolic or a hypoxic damage, which would show a diffusion restriction unlike rabies. So once we have diagnosed rabies based on clinical as well as radiological, now how to confirm? So investigation diagnosis wise, we have antemortem diagnosis. We can do it by nucleic acid detection. Though, as we can see, the sensitivity of CSF samples for nucleic acid detection is just 45%, and for salivary samples is for 88%. Antibody detection, as we can see in our case, the fourfold rise helps in diagnosis of the patient, though again, it has a low sensitivity of 36% in antemortem samples. The other test, what we can do is the viral antigen detection, which is not very widespreadly available. Also, the isolation of virus, which was done.
Ashish, we'll have to move on quickly. All right.
So what are the 3 samples we can send? Skin punch biopsy, CSF, saliva, or the serum, as we can see in our case. So treatment and complication, as seen in this case, we did use a Milwaukee protocol based on the 3 concepts of antagonizing the NMDA receptors by ketamine and amantadine. By therapeutic coma, we give an aggressive sedation in the first week and tackling the complications, which we can see, which we can predict in the subsequent few days. For example, in the first week, dysautonomia. End of the first week, you can see salt wasting. Further, we can see the catabolic state as well as the cerebral vasospasm in the first and the second week. But in spite of all this, so what is the success story? We say rabies is 100%, nearly 100% fatal. So if we look at the survivors in India, we have till date 15 survivors in India. So all these, what are the common things in them? All had grade 3 dog bite, but they lacked typical features of hydrophobia and aerophobia. As we can see, 93% had received post-exposure prophylaxis, and all of them had shown high titers neutralizing antibodies as seen in our case. So what really is helping our patient is more of this post-exposure prophylaxis, mounting an antibody response, and probably this Milwaukee regimen is helping us in buying the time to mount that antibody response. So definitely prevention is better than cure in this disease. This disease definitely is still we can see a resurgence because of increase in the stray animals. So India sees about 1.75 million dog bites every year. Chandigarh, my city itself, sees 40 dog bite cases daily. So that is the end of my seminar and also the basis of this time's World Rabies Day, which is collaborate and vaccinate. Collaborate and increase the knowledge about this and vaccinate as many dogs and also go for proper PEP after the bite. Thank you.
Great. Thank you very much for an excellent presentation. For somebody who's only seen 1 or 2 cases in 20 years, it's frightening. How many cases of rabies in India per year? Any idea?
20,000 in a year.
80. 20,000. Wolfgang, how about Austria?
Yeah, 1/3 of the world rabies populace cases are in India.
Well, Austria, I don't know. I mean,
1/3 of the world's population is in India, no? So not.
if there is 1 case every year, then it's reported. So it's very rare.
I thought you were going to say this was going to be Japanese bee encephalitis when you started, but you know, I think the history is everything, isn't it, in these things? So if there are no questions, maybe we'll go. Oh, hang on. There's a question from comment from Professor Anita Mahadevan. Saliva could have been tested, pooled 3 samples 6 hours apart, enhancing sensitivity of antemortem test result, especially because in vaccinated patients, antibodies interferes with PCR positivity. Post-mortem transnasal biopsy could have confirmed the diagnosis. So thank you, Professor Anita, for that comment. So I think probably in the question of time, we'll go to the last case. Dr. Singh Paul, are you there?
Yes, sir. Good evening, sir.
Hi, welcome. So will you present your case? Can everyone else please mute because there's a lot of background noise? Okay. Dr. Singh? Okay, go ahead. Dr. Singh, you're still muted. Can you unmute?
Okay,
yeah.
Is it fine? Good evening, everybody.
Yeah, go ahead.
Good evening, everybody. It's respected teachers and dear colleague. It's indeed a privilege to be with the WFN teaching seminars and sharing our case in this platform. I would like to thank Professor Meshram, Professor Gagandi for giving us opportunity to discuss this challenging and unsolved disseminated case which we came across. So going straight ahead to the case, this was 65-year-old gentleman, shopkeeper, presented with history of fever and malaise for last 3 months. There was history of loss of appetite and significant loss of weight, over 4 kg over 2 months. He also complained of some gradually progressive weakness, pain in the lower limbs, and difficulty in walking. So this was the history, and he's a known case of bronchial asthma for last 15 years. For that, he used to take a regime of its own in which he would take injectable hydrocortisone IV on alternate day, plus salbutamol inhaler in a dose of 200 to 400 microgram a day. He used to take this on alternate day for 2 or 3 months in a year whenever his symptoms used to get aggravated. In addition to that, he was using some alternative treatment in the form of powder, that is the Ayurvedic preparation, although the formulation we are not clear, but he was using for last 1 year because his symptoms are uncontrolled. So, and with this he would add up the injection steroids to this Ayurvedic preparation. He's vegetarian, non-smoker, and non-alcoholic. So, in view of his systemic features, not responding fever, progressive weight loss, pain in the limbs, he was admitted with the chest ward because he's a known case of bronchial asthma. There, on examination, he was found to be having febrile. There was features suggestive of steroid overdose was there. There was no cutaneous marker except for features of steroid overdose. Hemodynamically, he was stable. So he underwent an extensive workup for his fever, weight loss, and malaise. These are the investigations. His hemoglobin was 10. TLC was 7,000, platelet normal, ESR was 44. Rest of the investigations, including the culture, blood culture, urine culture, sputum, AFB, nocardia, blood serology, retrovirus, vasculitic panel, ACE level were all normal during the initial workup. So in the hospital course, he even underwent the workup for tropical fever, Brucella antigen, bone marrow biopsy, HRCT scan, which was also normal. So he received this treatment. He was still continuing steroids in a dose of 50 milligram IV, injectable antibiotic covering gram-positive and gram-negative organism plus supportive treatment. But he was not responding. He continued to complain of pain in the lower limb and inability to walking difficulty. So neurology consult was taken. When we saw the patient, his higher mental functions were normal. There was no meningeal sign. He was having generalized muscle tenderness involving lower limb proximal muscle as well as upper limb proximal muscle. His muscle power was 3/5 in the lower limb and 4/5 in the upper limb. Distal muscles were 5/5. Sensory examination was normal. Reflexive was normal. So then there was a thought process in our mind. Is it something systemic still we are missing? Is there a tubercular in view of history of pharmacologically immunosuppressed patient, or with maybe fungal infection, maybe parasitic infection with additionally steroid myopathy, or it is something malignancy which is going on somewhere in the lung or in other part causing a paraneoplastic syndrome of muscle involvement, or there is an atypical pulmonary infection with steroid myopathy, or there is an inflammatory muscle disease in presence of bronchial asthma, because it may be an autoimmune disease in this type of patient. So what we thought, let us think about and how to get, because most of the investigations has been done in this patient. So what we did, CT was inconclusive, CT abdomen was unrevealing, bone marrow biopsy was normal. So what we thought, let us get an NCV and EMG of this patient, because although he has systemic features, let us concentrate on his weakness, which we get on examination in the proximal muscles of the lower limb. So this was the NCV EMG. This revealed a myopathic pattern with spontaneous activity. So suggesting that there is something going on in the muscle, which is maybe inflammatory, maybe infective, anything of that sort. So one clue we got after that examination was there is something in the muscle. So now the thought process went back. Is it this goes, or then it may be a lung, something missing, lung malignancy or any malignancy with muscle involvement, or it is an inflammatory muscle disease in presence of bronchial asthma. So what should we say? We again thought of process that which investigation would yield us maximum result to us with comprehensive, that investigation should be comprehensive in making the diagnosis and giving us much of the information. So what do you think we could have done in this patient?
So thank you. So let's just stop there for a second. So you want to just summarize the case? It's a man who has fever, asthma, maybe immunocompromised with steroids. He's also taking these Ayurvedic medicines, and he presents with a myopathy. But with the normal CPK,
yes, sir.
His reflexes are present, so there's no nerve involvement. So it's a myopathic process. And you said it affects the upper limbs and lower limbs.
Proximal more than the distal one. Proximal, almost proximal.
What was the neck muscles affected, or the facial muscles?
No involvement of neck muscle, no involvement of facial muscle, but definitely there was muscle tenderness and muscle on palpation. They were tender and painful.
So, but still a CPK was normal. That's what upset me a little bit.
Yeah.
So maybe we could ask some of the other panelists to make a comment. And Wolfgang, do you want to make a comment?
Yeah, thank you. I would do an imaging. I would do an MR of the thighs or of the proximal muscles, or an ultrasound, just to see if there's inflammation, edema, or whatever.
No, I agree. And I think that would then give you the appropriate site for biopsy, because I think that's where you're going to end up going.
Sir, okay, so that was the same process we got into. We also thought about that, but we found that let us do an PET scanning. Why? Because we will be imaging whole of the body, one, in a single scan. Secondly, it will be a metabolic imaging of the body. Also, we will be able to evaluate any occult malignancy in this patient, especially anywhere, because it will image not only the brain or not only the muscle, as well as the other organs of the body. And it may be wiser in even if we pick up some lymph node here and there on PET scanning. This was the aim. So we went ahead with the PET scan in this patient, sir. And on PET scanning, what we found that you can see that there is a increased, this was whole body PET scan up to the mid thigh. We found that there was a avid lesion, which increased uptake was seen in the proximal muscles when we compared with the liver involvement in the shoulder muscles. This is the arm muscle. Similarly, there was extensive involvement of the thigh muscles on both sides, even tibial muscle. And to our surprise, what we found that there is even involvement of the sole muscles. So there is something which is going on in the body involving and also we can see here that even in this scan, there is involvement of the paraspinal muscles also. There is extensive involvement of the appendicular muscle, involvement of the axial muscles also. So then again, we thought, again, what could be this thing which is involving muscles of the peripheral as well as appendicular muscle, metabolically active disorder, and there is no other feature involvement of the lungs. I have not shown the film, but there was 2 lymph nodes which were prominent in the abdominal area, which were showing increased FDG uptake. So again, we thought, okay, sir.
So that's very interesting. Satish, do you want to make any comment?
I just wanted to say, I would repeat a CPK and make sure that it is normal.
Okay.
There is a lot happening on the scan. And secondly, you say the muscles were tender.
Yes, sir. They were tender.
That's quite unusual in inflammatory.
So we also repeat.
More often you see it with parasites in the muscles and things like that, or an osteomyelitis.
So you're right.
So the PET scan lighting up would perhaps go for an inflammatory type process rather than toxic, wouldn't it, really? We've got a few comments here. Serum myositis profile, so myositis antibodies.
Sir, that we have not done. Why? Because we go ahead once, as sir suggested, we repeated the CPK. Again, it was normal. So based on that, now we have evidence something systemic with fever, with weight loss, muscle involvement, proximal and inflammatory process. So what we did, we thought that let us get the biopsy first in this patient, which will help us in picking up the etiological diagnosis. So we went ahead with the biopsy in this patient first, rather. So this was the HNE stain of the skeletal muscle, which showed diffuse endomysial infiltrates are there. These are infiltrates which involving the neutrophil, histiocyte, plasma cell, and lymphocyte under 40. Then we did a pass scanning in that way and found that there is a granulomatous lesion with probably spores in these granulomatous lesions, suggesting a fungal infection. And we then do a GMCS stain, and we found that they were histoplasmosis. So there was one thing just I wanted to share with that, because before the biopsy, the patient said that he don't want to get biopsy because the treating other investigation, because there was so much have been done in this patient. He wanted that, let me go home. So we tried to convince him. The treating physician said that let us start now. You have enough evidence to start him on solumedrol. So why not to give him solumedrol, because this features favor that it may be having inflammatory. We went back, we tried to convince the patient, please get the biopsy done, because this may be the changing point in his diagnosis. And luckily, after convincing him, he agrees for the muscle biopsy. We did it. I think that was the learning for us in this patient. So what we did after that, we started him on itraconazole. Still he's on itraconazole, 6 months follow-up. Telephonically, we have asked him. Now at presently, there's no fever. His asthma is well controlled. There is no muscle pain. His power has improved. Now he's able to walk independently. He has even joined back to his shop profession also, and he has stopped all alternative treatment. And he said that he's fine, and he's still on itraconazole. So what we thought, what is known is that histoplasmosis, we know that it is a fungal infection, dimorphic fungus, which first localizes to the lung, and if you have a strong immunity, then there is no further progression. There is fibrosis and calcification of that infection. But if you have defective cell-mediated immunity, which we thought in this patient may be pharmacologically suppressed patient, so that may be the reason that he's spread it to the lymph nodes. But still it is a dilemma, or it is a mystery, that how it only reached to the muscle, and there is no other evidence. Even bone marrow biopsy in this patient was negative. So what was new in our patient was that we found that there was no other evidence except for the isolated muscle involvement, involving both the appendicular as well as the axial muscles. Plus there is a PET scan which is showing that there is even which helped us in this patient. So key messages which we think that we learned in this patient was that
Virinder,
yes sir,
since Dr. Anita Mahadevan is here,
yes sir,
can you just show the pathology slides and
okay sir,
our comment on Dr. Anita, are you there? Dr. Mahadevan?
I don't see her now. She was there, but
I thought it would be an excellent opportunity. Yeah. She's an expert in neuropathology, and we could have her
just left.
But I think she has just left. Okay.
Okay.
So please, Virinder, sorry, please carry on.
Okay. So sir, what we learned in our patient, that our patient illustrates a distinctive clinical presentation of infection and symptoms as fever, weight loss, and isolated muscle involvement. Nuclear study of the whole body guided us the diagnosis when the clinical and conventional imaging worked up negatively in identifying the symptom. And also I would stress that the key clue to diagnosis was obtaining the nerve conduction studies and EMG studies, suggesting that there is something infiltrative disorder which is occurring in the muscle in this patient, and muscle biopsy was the necessary next step to elude the cause, which revealed that the presence of yeast. And we got the rewarding results also, because once he started on treatment, he was so fine. I have personally seen that patient. He was very, I could see very toxic look, but I was unable to explain when I saw that patient, and when we discussed in the department that how to approach. So it was in fact a great learning and challenging phase. So we thought that let us share this our experience with this great panel of
it's a fascinating case. Well done. It was very good. So I presume the CPK being suppressed was because of the steroids.
Yes, we thought we also start all that may be the reason for that CPK was not elevated, and low muscle mass maybe. I'm not sure about that, sir.
Okay, no, so very interesting. So I think probably it's time to call it a. Professor Meshram, can I pass it back to you, please? Thank you, Dr. Singh, for an excellent case.
Thank you, sir. Thank you, sir.
Very interesting case. How common is this muscle involvement and fungal infection in the myopathy?
Sir, we have seen, sir, Dr. Gagan, sir. Anji, sir. Sir, you go ahead, sir. Sir, we have read that muscle involvement can be a contagious muscle involvement if there is a skin involvement, and muscle involvement is more common in patients who are HIV, that is immunocompromised. So as such, this extensive muscle involvement we could not find in literature. And although local infiltrative disorder can be there, but in absence of other organ involvement like lung, even PET scan don't show any lesion in the lung. Bone marrow is not showing anything of that sort. So
no report.
We could search to our best of knowledge, there is no report of such extensive involvement.
Thank you, Birinder. Nice, excellent case. Before I close, I think we'll have some comments from Dr. Raj Shakir about the series. Professor Raj Shakir.
Raj, are you there?
Yeah, I'm with you now. Thank you very much. Yes. Oh, this is fascinating. Every week there is something new, and every week we learn a lot. And I see the numbers of participants is fairly consistent, and the numbers are from everywhere. And I hope that I had comments from Latin America, and I'm really very pleased with this specialty group, which is really perhaps I chair the specialty group committee, and this is, I will say it very clearly, is the most active of all the specialty groups. And I'm really delighted with this, and we're doing wonderful times. And I think this, probably this series will probably, you're thinking of increasing the numbers beyond September, and that would be very useful. The timing is excellent, and I think we will just go ahead and get on with it, please. Thank you.
Thank you very much.
Can I just add in? So there's a message from Professor Anita.
Yeah.
I can only message. I think the biopsy is very conclusive. I would go with granulomatous myositis due to histoplasmosis. Fantastic case. So you have your acknowledgement there from Professor Anita, really. Back to you, Professor Mashram.
Yeah, thank you, Professor Riyad, for an excellent presentation, and thank you, Professor Grisold and Professor Hadi Manji and Professor Raj Shakir. I would thank Dr. Gagandeep and Dr. Satish Khadilkar and all presenters. Very excellent session. And next week we have a talk on encephalitis by Professor Serebznur from Turkey. And there will be 3 interesting cases. So please join next Saturday, 15th August, same time. Thank you very much.
Thank you.
Thank you.
Thank you. Bye-bye.
Bye-bye.
Bye.
Bye. Thank you.
Bye.
Thank you.
Bye.